say goodbye to monotonous books and say hello to colorful, interconnected mind maps. In this series, we will quickly help you revise important concepts with the help of mind maps, which you can access later using our app. In this video, we will quickly revise the topic of malignant tumors that arise from epithelial origin. Starting off with basal cell carcinoma, also known as basal cell epithelioma or rodent ulcer, which is the most common type of skin cancer in humans. It is a locally invasive and slowly spreading malignancy that arises from the basal cell layer of the skin and rarely metastasizes. The primary cause of BCC is a long-term exposure to ultraviolet radiation from the sun. As a result, it often develops on sun-exposed areas of the skin, such as the face, scalp, and ears, especially in elderly individuals with fair skin. Some individuals may be at a higher risk of developing multiple basal cell carcinomas due to certain genetic syndromes such as xeroderma pigmentosum and nevoid basal cell carcinoma syndrome. It is more common in people 40 years of age or older and more commonly seen in males. It is most commonly seen in the middle third of the face. Basal cell carcinoma does not typically occur in the oral cavity as it primarily affects the skin. However, in rare cases, it may invade and infiltrate the oral cavity if it arises from the adjacent facial skin. Basal cell carcinoma has different types. Nodular basal cell carcinoma is the most common variety of basal cell carcinoma. It typically presents as a raised, shiny, and pearly nodule with rolled borders. The nodule may have a central depression and it often undergoes cycles of ulceration, crusting, and healing. Over time, the tumor cells spread laterally beneath the skin, leading to a smooth rolled border around the central ulcerated area. Pigmented basal cell carcinoma shows increased brown or black pigment in addition to the features seen in nodular BCC. It is more commonly observed in individuals with darker skin. Cystic basal cell carcinoma lesions appear as translucent blue-gray cystic nodules. Superficial basal cell carcinoma presents as scaly patches that are pink to red-brown in color, often with central clearing. Superficial basal cell carcinoma is common on the trunk and has a low tendency to become invasive. Micronodular basal cell carcinoma is an aggressive subtype that is firm to touch and may have a well-defined border. Lastly, morpheoform and infiltrating basal cell carcinoma subtypes are aggressive and present with sclerotic plaques or papules. The border is usually not well defined and extends beyond clinical margins. Histologically, nodular basal cell carcinoma is characterized by tumor cells with large hypochromatic or oval nuclei and scant cytoplasm. These cells are arranged in nests of varying size. The tumor cells appear uniform and mitotic figures are relatively few. At the periphery of these nests, there is a characteristic palisading pattern where the tumor cells align in a linear arrangement resembling a fence. The treatment and prognosis of BCC are generally favorable when detected and managed early. Next, we come to squamous cell carcinoma, also known as epidermoid carcinoma. It is a malignant epithelial neoplasm that exhibits squamous differentiation characterized by the formation of keratin and or the presence of intercellular bridges. It is the most common malignant neoplasm of the oral cavity and has a male predilection. The development of SCC is influenced by various risk factors. These include tobacco smoking, smokeless tobacco, betel quid chewing, alcohol consumption, exposure to phenolic agents, radiation exposure, iron deficiency, vitamin A deficiency, syphilis, candidal infections, oncogenic viruses, immunosuppression, and abnormalities in oncogenes and tumor suppressor genes. The use of tobacco in any form is one of the primary causes of oral cancer. Smoking and smokeless tobacco use significantly increases the risk of developing squamous cell carcinoma. Excessive exposure to ultraviolet light, particularly on the lower lip, is associated with an increased risk of developing squamous cell carcinoma in that area. Certain genetic disorders such as xeroderma pigmentosum, Fanconi's anemia, and Bloom's syndrome can predispose individuals to the development of oral cancer. Trauma, in combination with other risk factors, may act as a co-carcinogen, increasing the likelihood of SCC development in affected areas. Clinical presentations include ulceration and an indurated margin. Carcinoma of the lip occurs chiefly in elderly men. The lower lip is involved far more commonly than the upper lip. The most common site for intraoral carcinoma is the tongue, usually the posterior lateral and ventral surfaces. Grading of oral squamous cell carcinoma can be done as well differentiated, moderately well differentiated, and poorly differentiated. This can be noted down in detail from this section of our mind map. Metastases from intraoral carcinoma of different sites involve chiefly the submaxillary and superficial and deep cervical lymph nodes. Surgical excision or X-ray irradiation is the primary treatment modality. The prognosis for survival from oral cancer depends on the stage of the tumor. Moving on to the next one. Malignant melanoma is the third most common type of skin cancer and originates from melanocytes. It can arise either from a pre-existing benign melanocytic lesion or develop de novo from normal skin or mucosa. Ultraviolet radiation from the sun is a significant causative factor for the development of melanoma. The growth of melanoma is characterized by two phases. Firstly, the radial growth phase. In the early stages, melanoma exhibits a radial growth pattern. This phase is predominant in certain subtypes of melanoma, such as lentigo maligna melanoma, superficial spreading melanoma, and acral lentiginous melanoma. During this phase, the malignant melanocytes tend to spread horizontally within the basal layer of the epidermis. Secondly, the vertical growth phase. As the disease progresses, the melanoma cells invade the underlying connective tissue, initiating the vertical growth phase. This phase is more commonly seen in nodular melanoma, where the radial growth phase is minimal or absent, and the melanoma cells predominantly grow vertically. There are various types of melanomas. The superficial spreading melanoma is the most common type of melanoma. It typically starts in the radial growth phase. It is often known as pre-malignant melanosis or pagetoid melanoma in situ. Second is nodular melanoma. This type of melanoma does not show a clinically recognizable radial growth phase and exists solely in the vertical growth phase. The next one is lentigo maligna melanoma, which is characterized by its radial growth phase. Known as lentigo maligna or melanotic freckle of Hutchinson. It is commonly seen as a macular lesion on the malar skin of middle-aged and elderly individuals with fair skin. Acral lentiginous melanoma develops on the palms, soles, toes, and fingers. It is highly aggressive and rapidly progresses from the radial to the vertical growth phase. Mucosal lentiginous melanoma are another type, which arise from the mucosal epithelium that lines the respiratory, gastrointestinal, and genitourinary systems. They are often diagnosed in advanced stage patients and can be aggressive. They may appear as erythematous or pink eroded nodules. Lastly, amelanotic melanoma refers to a subtype of melanoma where the tumor cells do not produce melanin. This makes them appear erythematous or pink. Histologically, the malignant melanoma displays certain characteristic features such as the tumor cells may form clusters in an organoid fashion or may predominate as single cells. Melanoma cells typically have large nuclei with visible nucleoli, indicating active cellular division and proliferation. Due to irregularities in the nuclear membrane, nuclear pseudo-inclusions can be observed in melanoma cells. Melanoma cells may have abundant cytoplasm, which can appear uniformly eosinophilic or optically clear. Lastly, buckshot scatter refers to the uneven distribution of melanoma cells in the radial growth phase. It gives the appearance of scattered malignant cells in a pagetoid manner. The ABCDE clinical features of melanoma are used to aid in early detection and evaluation of suspicious skin lesions. It stands for A. Asymmetry. The lesion is asymmetrical when one half does not match the other half in shape or size. B. Border irregularity. Melanomas often have an irregular or notched border. C. Color variegation includes shades of brown, black, white, red, and blue, reflecting different depths and concentrations of melanin pigment. D. A diameter greater than 6 mm. E. Evolving. Melanomas often show changes over time, such as growth, shape alteration, color variation, or other symptoms. This table gives the Clark system for grading of malignant melanoma. You can pause the video here and make a note of it. Surgical excision is the choice of treatment for melanomas. Oral mucosal melanomas have a far worse prognosis than cutaneous melanomas. Now, we come to a very important question that is asked in your exams, the TNM classification. The classification can only be applied once histological confirmation has been made. It is a standardized way of describing the extent of the primary tumor T, regional lymph node involvement N, and distant metastasis M. The stages are then grouped based on these classifications to provide an overall stage of the cancer. The TNM classification for oral cancer is as follows. T for primary tumor. TX stands for primary tumor that cannot be assessed. TO, no evidence of primary tumor. TIS, carcinoma in situ, pre-invasive cancer. T1, tumor 2 cm or less in greatest dimension. T2, tumors more than 2 cm but less than 4 cm in greatest dimension. T3, tumor more than 4 cm in greatest dimension. And T4, tumor invades adjacent structures. For example, through the cortical bone, tongue, skin of the neck, deep muscles of the tongue, maxillary sinus, skin. N, regional lymph nodes. NX, regional lymph nodes cannot be assessed. NO, no regional lymph node metastasis. N1, metastasis in a single ipsilateral lymph node 3 cm or less in greatest dimension. N2A, metastasis in a single ipsilateral lymph node more than 3 cm but less than 6 cm in greatest dimension. N2B, metastasis is multiple ipsilateral lymph nodes less than 6 cm in greatest dimension. N2C, metastasis in a bilateral or contralateral lymph node less than 6 cm in greatest dimension. And N3, metastasis in a lymph node more than 6 cm in greatest dimension. M, distant metastasis. MX, presence of distant metastasis cannot be assessed. MO, no distant metastasis. Or M1, distant metastasis present. On the basis of this classification, TNM stage grouping is done as Stage 1, T1 NOMO, Stage 2, T2 NOMO, Stage 3, T3 NOMO, or T1, T2, or T3 N1MO. Stage 4A, T4A NO, or N1MO, or T1, T2, T3, or T4A N2MO. Stage 4B, NET N3MO, or T4B NEN-MO. Stage 4C, any M1 lesion. Another important malignancy to remember is verrucous carcinoma, about which you can take a look at this section of our mind map. With this, we have come to the end of this video discussion. Hopefully, we have helped you revise this topic quickly. You can head over to the MCQ section on our app and try solving a few questions now. Happy learning!